I think this is a pre-recorded lecture of Dr. Bhupesh BAGGA again, who could not attend this meeting. So if you can play that lecture.
Distributed geographically, mainly among tropical countries, subtropical and temperate regions.
Can you play it, okay?
It is, hello everyone, I have no financial disclosure regarding this talk. Pythium introduction keratitis is distributed geographically, mainly among tropical countries, subtropical and temperate regions. It is having basically 4 clinical subgroups. The most common is vascular, which is around 59%, followed by ocular, 33%, cutaneous and subcutaneous and disseminated cases. Risk factors of non-ocular pathiosis is thalassemia, hemoglobinopathy syndrome, while ocular pathiosis is more commonly seen in rainy season, associated with farming exposure, direct contact with water resource or use of contact lens. Pythium basically belong to a group called as oomycetes and family Pythiaceae. But if you see the historical facts about this organism, it was first described as fungus in 1880 by Smith et al. Because lack of sporulation was there, it was described as hypomycosis destruens by Bridges et al. Later on, it actually differentiated from fungus as oomycete. But phylogenetically, it resembles more with algae than fungi. So regarding the life cycle of Pythium, the most important part of Pythium is zoospore, actually able to generate in our laboratory with the help of carnation leaves in aquatic media. As you can really observe, there are formation of zoospores from the microsporangia. So it is important to know about Pythium because of different response of these two organisms with the use of antifungals. As you can observe here, fungus resolved with the use of antifungals, with the Pythium worsened with the use of antifungals, which are there with Pythium keratitis. Is difficulty in making a diagnosis because it closely mimicking fungus clinically as well as microbiologically, and difficulty of treatment because it is non-responding to antifungals. So there are certain investigations, like in microbiology, gram stain, as I previously described, is a broad aseptate ribbon-shaped filament. It takes GMS stain as of the both, but in KOH we can differentiate it from fungus because of aseptations and broad and ribbon-shaped. PAS stain is also able to differentiate between these two organisms because Pythium is not taking stain versus fungus takes stain of PAS. Our group, led by Ruchi Mittal, described a novel diagnostic staining technique made of IC387, where you can see fungal filaments, the Pythium filaments are appearing as a blue color instead of always specific. Another way is to differentiate is from quality of growth. Whereas Pythium is more of feathery edged, slightly submerged and flat and pressed type of terrain, while as a fungus is classically described as raised and white cottony color. The feature is the formation of zoospore, which is we can produce in our laboratory with the help of carnation leaves. When we took this growth from solid media to aquatic media, the formation of zoospores as can be observed in these two videos. Another way to diagnose is by help of PCR. Treatment was again a second challenge after making a correct diagnosis because it doesn't respond to antifungals, as has been observed in various studies that existing antifungals are not effective against Pythium infections. As observed here, out of 46 cases, 42 underwent surgery, keratoplasty, and in that 26 actually recurred back. And the results of those are not that much great. So the conclusion was the treatment of Pythium keratitis is surgical, but 50% of TPKs also had a recurrence after transplant and requiring resurgery. So as can observed in this patient, after successful grafting, taking a large graft also, there was a recurrence of Pythium. Here also it is a very 360-degree recurrence from the host site and finally led to the dissolution of the eye. Our experience 2015 was not different from others, and we observed nearly 90% of cases undergoing transplant for resolution of infection with almost every graft was filled. So difference between the Pythium, why this is response, lies in the structure of its cell wall, because it lacks ergosterol, and we know that antifungals works through use of ergosterol synthesis, stopping the ergosterol synthesis. So why this is happening? The cause of poor response to antifungals in Pythium lies in its peculiar cell wall, which lacks ergosterol, and as we know, antifungals works by stopping ergosterol synthesis. That is the reason Pythium does not respond to antifungals. We did trial of anti-Pythium susceptibility in our lab, where we found that linezolid, minocycline, tigecycline, followed by others, erythromycin, were having susceptibility against Pythium. So based upon that trial, we performed and made a challenging rabbit model of Pythium keratitis. Dr. Savitri Sharma led this trial, and as we can observe here in this video, the rabbit cornea was used for making in vivo model of Pythium, where we injected zoospores intrastomally in the cornea and then treated with the use of these antibiotics. As we can observe here, in the linezolid group, there was success of 50%. Erythromycin group, there was success of 33%. Based upon these observations and antifungal susceptibility group, we combined and come out to be this treatment that will combine linezolid and erythromycin and give to our patient. And there was again challenge because there was no topical linezolid was available. So we decided to go direct concentration of linezolid as a topical along with erythromycin ointment or drops medications, along with oral linezolid or oral erythromycin as a combination. Based upon this experience of in vivo and in vitro antibiotic susceptibility testing, this is our first patient we managed with a combination of these two antibiotics, and this was a 3.7 to 1.4 millimeters with smaller infiltrate with a confirmed Pythium, and it responded in 1.5 months. So we conducted pilot trial and come out with the treatment in our publication. It is called as Leap Forward in the Treatment of Pythium keratitis. And here are some responses. You can observe in the size of 7 to 8 millimeter Pythium started responding to the treatment, and even the larger advanced form of Pythium keratitis also being managed on medical round. And this is the typical response which we achieve with the use of medical management. And we come out with what are the signs of resolution, how to differentiate between the worsening and resolution. So clinical signs of resolution starts usually 10 to 14 days. The median time to resolve with medical treatment is around 3 months. And usually first sign is blunting of edges, the tentacles, with fading of pinhead-like lesions, as it can be observed here. Another classical sign is guttering around the infiltrate. It also appears in many cases that sometimes thinning is more, so we have to apply glue and damage contact lens. So these are the classical signs of resolution as mentioned before. Not only it's improve the medical management, but also improve the surgical management. Cases who didn't respond to medical management and kept on worsening due to advanced stage at the time of presentation, we performed therapeutic keratoplasty, but fortunately none of the case came with a recurrence. So this case underwent therapeutic keratoplasty because of worsening of Pythium keratitis. Later on failed graft and underwent desec. The outcome is quite nice with vision of 20/20 restoration. So based upon experiences gained in last 5 years, we come out with this management algorithm that whenever you have these clinical signs such as tentacles, pigment lesions, guttering or black lesion, and patient is on worsening on antifungals, start thinking in line of Pythium keratitis. Look carefully grams and KOH smears, culture as well as perform PCR to confirm Pythium, the formation of zoospores in aquatic media. After confirmation, start the patient on antibiotics in combination for 10 to 14 days and observe carefully to find the response. Then continue the same treatment if found to be worsening. Then go with therapeutic ketoplasty with extra large margin. If no, continue same treatment and observe carefully with the thinning or posterior.